And that's Cynthia Ogden, who's come all the way from the Centers for Disease Control in the US. She also teaches at George Washington University in Washington, D.C. She's an epidemiologist and has been overseeing the National Health and Nutrition Examination Survey for the CDC and has a wealth of data on levels of obesity, on diet and dietary choices among the US population. So she's going to share some of her research with us today. She's worked on a revision, just a couple more things in her bio here. She worked on the revision of the CDC growth charts for children that are used to define obesity among children in the US. So this is another wonderful piece of research that she's been doing and she's going to share with us today. So we're happy, privileged, in fact, to have her here all the way from Washington to speak at our lunch. And so, Cynthia, without further ado, I'll hand over the controls.
Thank you.
We're going to have time for some questions when Cynthia wraps up. So if you think of something you want to ask, stand by and I'll call on you after we're done. Thanks.
Thank you very much for that lovely introduction, and thank you very much for inviting me here, Michael, and to the United States Studies Center as well. I'm very excited to be here. I've never been in Australia, and so it's my children were very jealous, I should say. So I'm very happy to be here, and I'm delighted to talk to you about obesity and diet in the United States. It's quite relevant to be talking about obesity while everyone's eating, but my talk's going to be very different than the other conversations today, and but I'm hoping that it will kind of provide a little bit of kind of data in the background of what's going on, and you can think about how what's going on in the United States relates to what's happening here in Australia. I'm going to talk about kind of four areas. I'm going to talk about obesity and have some global context so that you can see how what's happening in the United States is worse than in most other places. And then I'll talk about diet in the U.S. And of course, diet is only one of the contributions to obesity, but I'm just going to focus on that part. And because I'm an epidemiologist, you're going to have to bear with me. I'm going to just give you 3 slides on data and how we collect the data on obesity and diet, because I can't possibly just tell you these things without you being able to judge whether you think these data are any good anyway. And then I'll turn to a few things related to recommendations on obesity prevention from CDC, including some comments about food labels in particular. So the most recent data in the United States are from 2009 and 10, and they suggest that 17% of children and about 36% of adults are obese. This translates into more than 90 million obese Americans, and that's about 78 million adults. So, I think prevalence is one way to look at it, but I think you also need to understand the burden by looking at what does that mean in terms of numbers in the United States. How do we get to be so obese in the United States? Well, this graph shows data back to the 1960, which was when we first had measured data that we could look at obesity. And this is my wave graph. I just learned how to do this in PowerPoint, and I kind of liked it. So it shows overweight, obesity, and extreme obesity. And you can see since 1960 that the prevalence of overweight has been level. This is the total adult population. And that's true for men and for women as well. But what's happened with obesity and extreme obesity is that it was pretty level until about 1980. And then there was an increase between 1980 and today in both obesity and extreme obesity. What this translates into is that an American man is 30 pounds heavier today than in 1960. For a woman, it's about 40 pounds heavier, the average woman. And for an average 11-year-old boy, it's 19 pounds heavier. And it's similar for an average 11-year-old girl, about 19, 20 pounds heavier. I know that this isn't kind of in the purview of just talking about obesity and diet, but thinking about the consequences of obesity, of course, cardiovascular disease is the leading cause of death in the United States, but diabetes is a big challenge, and 25.6 million adults in the United States have diabetes. That's about 11%, a little over 11%. And about 55% of adults with diagnosed diabetes are obese. Luckily, although people are talking much more about type 2 diabetes in teenagers now, the prevalence of type 2 diabetes in teenagers in the United States is still very low. So if you look nationally, the prevalence is actually less than 0.25%. However, now we are seeing cases of type 2 diabetes in teenagers, which was new. So luckily it's not so high, but we are seeing it. So that's not good. I have to tell you about definitions. I gave a talk recently where I didn't get to the definition until a few slides later, and someone shot up their hand and said, well, how are you defining all this? So I really have to give you definitions. You all probably know all this. Obesity is defined usually by using body mass index, which is weight over height squared. And in adults, there are really set definitions. Overweight is a BMI between 25 and 30. Obesity is a BMI at or above 30, and extreme obesity is at or above 40. And there can be different classes of obesity, so you can look at a BMI at 35 as well. But in general, these are the categories we look at it. Now with children, it's a little bit different. The definitions that people use are not all the same. So when you compare across countries or across studies, you can't always just assume that the definitions are the same. And in the United States, we use the CDC growth charts as the basis for the definition because with children, you can't set a BMI, just a strict BMI cut point, because there's differences by age and by sex. And you can see there the BMI growth chart on the right, how there was a big change in BMI, and you couldn't set something that would work for a 2-year-old and for a 10-year-old, just one set cut point. So what happens is you compare a child or a population to a reference population. And in the United States, we use the CDC growth charts, which are data from children in the United States from the 60s and 70s primarily. So by definition, 5% of kids in the 60s and 70s were obese because the 95th percentile was used as a cut point for obesity. There are other reference populations that people use, and in fact, when I looked for data from Australia on obesity, a different reference population was used. So I did convert some of the US data to using that reference population so you can see some comparisons. But just to understand that it's a statistical definition in kids compared to the more risk-based definition in adults. Another thing that I like to point out is that BMI is really not a perfect measure of body fat. This is one reason why in the work that we do, and when I have conversations with people, I really focus on obesity and not overweight. So this is a graph that looks at the prevalence of high body fat based on DEXA scans, so actual measurements of body fat. There isn't a agreed upon definition of what excess body fat is either. So we pick something that is somewhat, it is seen in the literature for this graph. And we looked at the prevalence of high body fat in the 3 BMI categories. This is in girls 8 to 19 years of age. And so there are a couple things you can see. One of them is that in the obese category, the majority of those kids have excess body fat. The next thing is that in the overweight category, probably only about half of those kids overall have excess body fat. And you probably know that overweight, there's a lot of misclassification just because BMI is a measure of body mass, not just body fat. And then the third thing is that there are big differences by race ethnicity in the United States. I can only look at 3 groups right now, although in the next phase of the survey, we're going to be able to look at Asians. But right now, it's just whites, African Americans or blacks, and Mexican Americans. And you can see that African Americans have significantly less body fat at the same BMI level compared to whites and Mexican Americans. So the bottom line is BMI isn't perfect, but it is what we use. We have significant disparities in obesity in the United States. And this shows race ethnic disparities in obesity prevalence And we find them in women, but not in men. So that you can see here that the highest prevalence of obesity in the United States is among non-Hispanic Black women. It's almost 60% are obese. So there are significant differences. And Hispanic women are also higher than white women. But there's no difference among men between the three major race ethnic groups that we can look at right now. So there was no significant difference. If you look at children, you see a very similar pattern to adult women in terms of girls. The pattern is very similar. But in terms of boys, you actually see a different pattern where Hispanic boys have a higher prevalence of obesity than whites or African American boys. And so this is a big area that people are quite concerned about in many communities, is this increasing prevalence of obesity in Hispanic boys. Oh, this is the graph on children. I guess I thought I'd taken this one out, but I was trying to save time because I could talk about obesity for a long time. So this shows that this difference that I just talked about among Hispanics, in this case it's Mexican Americans only, that this is a new phenomenon. Back in the late 80s, there was no difference in boys but in the three race ethnic groups, but there is now. So there are different things happening in different groups in the U.S. I cannot emphasize enough that when you think about obesity, you think about SES, that it's not just the low-income population that is experiencing obesity, at least in the United States. And in fact, what you see in men is the prevalence of obesity there's no difference overall in the three, and when you look at three income groups, there's no difference at all. And when you look at some groups of men in the United States, you actually find a higher prevalence in the highest income group. And so this notion that it's just low-income people isn't true. That said, among women, there is that strong inverse relationship, and it's particularly driven by white women, where the prevalence is lowest in the highest income group in white women in the United States. So it's a much more complex kind of story related to income and SES and obesity in the United States. I often get asked, has the prevalence of obesity plateaued in the United States? And in fact, I was working with a colleague that I unfortunately have never met in person in Adelaide, Tim Olds, on a paper looking at prevalence of obesity in children in a whole lot of different countries. I would wish I had the opportunity to actually meet him in person, but we have been looking at trends a lot. So this is looking at adult obesity over the last 12 years in men and women, and you can see immediately that maybe there's something different in men and women going on. I like to say that men have caught up with women in the United States in terms of obesity, and what you've seen is that the prevalence of obesity has increased recently in men from 27% to about 35, a little over 35% in men, but there's been no change in those 12 years in women. We are just now analyzing new data and hope to have that completed later in the year to look at data from 2011-12. This is looking at youth and boys and girls, and just like in adults, there was an increase in boys, but not in girls. And so there was an increase from 14 to 18.6%. Interestingly, though, in the more recent years, we haven't seen a change in prevalence. I don't know how many statisticians or people out there are, but I like this graph a lot. This shows the distribution of body mass index, and this is boys, U.S. boys, 12 to 19 years of age, and it's in the late 80s to 1999, 2002, and then 2007, 2010. And if I had shown a graph from earlier, in the 60s, the curve would be over further to the left. And what you've seen is the whole distribution is shifted, and it's shifting to the right, and it's becoming more skewed. And if you look at the 90th percentile, you see here that there was a bigger change between the late 80s and 1999 than there was more recently. So whatever happened in the 80s and 90s appears to be slowing down some. It's not quite the same rate of change as was happening at that time. This shows the prevalence of excess weight in young children birth to 24 years of age, where there's really been no change recently. This is a whole different area of research. You don't really use BMI in this age group and a variety of other things, but basically there's been no change in that age group. And this is just to reiterate that recently, since, in the very recent data from 07-08 to 9-10, that we saw no significant change. And in particular, you can see among kids that it really was 17% obesity in 07-08 and 9-10, so really no change at all. In adults, the change was not statistically significant. What about the global context? So I searched around and got some data on Australia to compare to the US. And this is the prevalence of overweight or obesity. So this is a BMI at or above 25 in adults. And you can see the dates aren't quite the same from the surveys. So I put the dates at the bottom, and the one on the left is Australia and the one on the right is the US. But I think they're close enough to make the comparison. And you can see in the 90s, around 95 or so, that the prevalence was very similar in Australia and the United States, 56%, the same. But in 07-08, there was an increase in both countries, and then an increase in Australia more recently, but no increase in the United States. But you can see the difference between the countries, whether it's significantly higher in the United States than it is in Australia. And if you look just at obesity, it's about 28% versus 36%. So it is higher in the United States than it is in Australia. And this is the most recent data from both countries. When I saw this, I was quite alarmed. This is the prevalence of overweight or obesity in youth. And this is not using the standard definition that we use in the United States with the CDC growth charts, but using the International Obesity Task Force definition, which is what this figure from Australia, the 25%, was. So we did some calculations and found that it's 40% in the US compared to 25%. The age groups are slightly different, but this is, school-age kids, 6 to 11-year-olds, 40%. It's very high. Turning now to Canada, we see that in the US it's higher than it is in Canada. 36 versus 24%. Some work that we did with Canadians, because they have a survey that's very similar to ours. And again, differences, you see the same differences by age, although in the older age group that the difference between the two countries is diminishing. And this is looking at kids in Mexico and Canada and the United States. And the only significant difference in obesity, this is going back now to the CDC growth chart definition, the only significant difference was that here, statistically significant, was that the US girls, 15% was higher than in Mexico or Canada. And you can see that in Mexico and Canada, the prevalences are the same. And here are trends in youth in England. Where there appears to be some decrease. I didn't check to see if there are more recent data. I should have done that beforehand. But there really, if you look over this whole time trend, there hasn't been an increase in obesity in England in kids. All right. So that's the end of my obesity talk. I really did try to narrow it down to those graphs I thought were most interesting. But I'll talk to you about diet now. I think there are all kinds of interesting sources of information on diet in the United States, and I wanted to show you a couple things that are based on agricultural data. So if you just look at food supply, just calories per capita available, you can see here, this is showing 1970 all the way out to about 2010, that the calories available per person went from 2,076 to 2,534. So just the availability of calories per person has gone up. You can also translate that into data looking at consumption. And since the late 70s until the most recent data, there's been about a 200 calorie increase in adults in the United States on average in terms of consumption. So both, I like it when things match, the agricultural data and the consumption data, that's good. But recently, we have seen a decrease in calorie consumption. This shows a change in youth, that there's been a decrease in both males and females over the last 12 years, from 1999-2000 to 2009-10. And we've seen a similar decrease in adults, so that there's been some decrease recently in consumption in calories. But of course, calories is really not the whole story at all, by any means. We really need to look at food. So this is kind of move into what people are eating, how has that changed. So here's, I think, a nice slide of kind of foods consumed in the 1950s. Whole foods, not very many processed foods, right? And look at foods consumed today. And I think this is pretty typical in an American diet today. So there's been a radical change in what Americans are consuming. And you can even see here, this is looking at between the late 80s and the early 2000s, so maybe 10 years ago. And I show this one because it's quite dramatic. If I showed you data from the late 80s to today, the increases wouldn't be as big because it's gone back down. But salted snacks up to 320%. This is in school-age kids, 6 to 11. Candy increases, mixed dishes increases, and pizza increases, 425% increase in pizza consumption among kids. And guess what? A decrease in vegetable consumption. So it's quite dramatic. But let's look a little bit now more broadly at dietary patterns. And in particular, it was noted earlier today that added sugars is a problem in the United States and not so much in Australia. So you'll have to bear with me because added sugars really are a problem in the US. And so I'm going to focus for a minute on that, partly related to beverages. So if you look at percent of energy from meals and snacks or foods and beverages, you can see that in the most recent data, snacks accounted for 26% of energy, which is pretty high, and beverages 20%. This compares to the late 70s, where snacks accounted for only 12% of calories and beverages 16%. So there's been a shift in kind of how people eat. They're snacking more and consuming more beverages relative to the food that they consume in terms of energy. And this graph actually just shows you the frequency of snacking in 2009-10 among whites and among blacks. And I think there are two things to note: that look how low the frequency of zero snacking is. That it's among whites, maybe 3% of the population consume no snacks per day. And if you look at 4 or more snacks per day, it's almost 40% of whites consume 4 or more snacks per day. It's very high. And if we look at, I'm showing you children's diet, but I could show you adults' diet. It would be the same thing, that carbohydrates are the biggest contributor to diet. But this is really getting at the whole issue of added sugars. So if you look here at kids, it's about 54% of the diet is carbohydrates. And of that, about a third, 30%, is added sugar. Most added sugars are actually found in foods, not beverages. So about 59% of the added sugars that kids consume are from foods. And in fact, when we first published this, people didn't like it. They got upset with us. Oh, no. Because sugar-sweetened beverages are the single item that are the largest contributor of added sugars. So if you combine all the foods and all the beverages, it's food. But if you just want to look at specific items like cakes, pies, candy, whatever it is, and then sugar-sweetened beverages, it's going to be sugar-sweetened beverages that is the biggest contributor to in terms of added sugars. But I think it's important to note that you're still getting a significant amount of added sugar from food, not just beverages. This is going back to agricultural data, and you can see that this is gallons, per capita gallons available of soft drinks and milk. And you can see what's happened. Milk has gone down, soft drinks have gone up, and just in terms of availability in the food supply. So it's been a big change. Now we're turning back to consumption data on sugar-sweetened beverages. And the thing of note here is that really teens and young adults are the biggest consumers of sugar-sweetened beverages by far. So if you look here at the 12 to 19-year-olds, and particularly males, huge consumers. This is in calories, the average calories consumed from sugar-sweetened beverages among 12 to 19-year-olds and 20 to 39-year-olds. And really, they make up the group that consumes the most. But recently, we just published something actually in May looking at trends in soda and all the sugar-sweetened beverages. And we've seen a decrease between 1999, 2000, and 2009-10 in soda and fruit drinks. But energy drinks and sweetened teas, we've seen an increase. It's hard to see, I guess, the colors. There's a purple line there too. But there was an increase in sport or energy drinks and sweetened teas. But notice that the contribution in terms of calories per day is very, very low compared to fruit drinks and sodas. That they're still the biggest contributor of sugar-sweetened beverages, because this is a big thing where I see we have to have a long discussion about how we're defining sugar-sweetened beverages and making sure we include those little drinks. But really, these are the big players here. This also is looking at trends over time and the frequency of different portion sizes of sugar-sweetened beverages. And so this shows you that today about 36%, more than a third of youth don't consume any sugar-sweetened beverages on a given day. And among adults, that's even higher, that do not consume. So that's been going up, the non-consumers. And then those up here in this highest group, this is the more than 24 ounces, this has gone down from 12 to 8% of the population. So there have been some changes in terms of sugar-sweetened beverage consumption. What about portion sizes? We've been talking about that. Well, portion sizes are giant in the US, although I have to tell you that since I've been here the last couple nights, that the portion sizes I've been getting on my plates have been very large. So, this is a graph that Marion Nussel published some time ago, but it looks at soda sizes at 4 different places: Burger King, McDonald's, 7-Eleven, and Coca-Cola, and the year that it was introduced, and then what size you could get in ounces at that time. And I'm particularly impressed here with Coca-Cola. In 1916, you were getting 6.5 ounces. And then, this is, again, 10 years ago, more than 10 years ago, but at that time, you could get 34-ounce Cokes, 64-ounce sodas at 7-Eleven. Now, who needs 64 ounces of soda? And 42 ounces up at these other places. So tremendous changes in portion sizes. And in fact, I was looking at trolling around on the internet one day, and I found at the National Institutes of Health in the United States that they have a portion distortion interactive quiz. And so if you're interested, you should go there. Actually, 2 of them. And I'm going to show you a few graphs from this interactive quiz, but I'm going to only show you the answers. And so I won't quiz you. But this is looking at coffee 20 years ago versus today. And so just coffee with milk and with whole milk and sugar. And now a mocha coffee with steamed whole milk and mocha syrup. And we've got 45 calories in this 8 ounces 20 years ago, and 350 calories in the 16-ounce coffee, with a difference of 305 calories. And I have a few more from this quiz. This shows you pepperoni pizza. The changes, a difference of 350 calories in what, today people are getting these 2 big pieces versus what they were getting before. And here is a chicken Caesar salad, and a difference of 400 calories. That the portion size 20 years ago was about 1.5 cups. Now it's 3.5 cups. And popcorn at the movies. I don't know. Do you have this size popcorn at your movie theaters? Yes? Well, I don't know. They look huge when people are carrying them around. But So 5 cups before and versus 11 today, 360 calorie difference in those portions. And so that, this is kind of, people consider this normal in the movie theater, that, I'm just going to buy this large serving of popcorn. And then a cookie, from 55 calories to 275 calories with a 220 calorie difference. So just kind of what this idea of what a portion size is and what we think is a portion size, well, this is normal, this has really changed. And you look at some of the things you get in some of the fast food places, some of the large in the United States, kind of doughy things, they can give you as many calories as you need in a day. So. Another thing we've seen in the United States, and this was touched on earlier, is eating outside of the home. This has really been a huge change in terms of the way people eat. This shows you just expenditures and how it's gone from, it's increased in terms of the percent of income since 1970. But in particular, if you look at calories consumed from away from home, it's 33% of calories are consumed away from home. That means a third of the time about people are eating outside of the home. And so thinking about restaurants and fast food is important if you're going to think about people's diets. This compares in the late 1970s to only 17%. So a huge change in how people eat in terms of where people are getting their calories and their food from. If you look just at fast food, so away from home can be anything like what we're doing now to fast food, of course. And so if we just look at fast food, we see that the energy consumed from fast food decreases with age. And so really, just like in the sugar-sweetened beverages, it's young adults that are really consumed. This is just in adults. I don't have it in children right now. That it's really young adults who are getting 15% of their calories from fast food on average. We also see that obese adults in the United States get more energy or calories from fast food compared to underweight, normal weight adults or overweight. It's actually a kind of a linear trend. It's 13% versus 18% of their calories. But more recent data does show that there's been a decrease in the percent in terms of the calories, I should say, that are obtained from fast food. And that's particularly because of this middle-age group, the 40 to 59-year-olds, where it went from 12.7 down to 10% of the calories. But that was a significant decrease, and the overall was significant as well. This is not statistically significant, and I don't think this one is either, but the overall number was, and so was it for this 40 to 59-year-old. So there was a decrease recently in fast food and energy from fast food. So here are my few slides on where all this comes from. It comes from the National Health and Nutrition Examination Survey, and this is where I work, and I oversee all the researchers and analysts in this group who analyze. It's an enormous survey. Approximately 5,000 people are surveyed each year. 4 trucks make up the mobile examination centers that travel around the country. And there are 2 sets of trucks that are going around at different times. The survey itself consists of an at-home interview, which can last for 2 to 3 hours, and then a physical exam in a mobile exam center that lasts about 3 hours. And it's enormous. There's an oral health exam, there's a DEXA scan, there's a large blood draw. So it really covers a broad range of things, including anthropometry, which is my interest, and dietary intake. So there's a 24-hour dietary recall in the survey. This is one of the more time-consuming components of the survey, as you can imagine, if you know anything about obtaining dietary information. When you ask people what their weight and height are, you really don't get very good information. You really want to measure them because women tend to underreport weight and men tend to overreport height, kind of on average. But you can imagine that asking people about diet is even more tricky than asking people about their height and weight. It takes time, and there's error associated with it. But there's an in-person interview, and then there's a follow-up interview some weeks later over the phone. So a second 24-hour recall is done to obtain what you ate in the last 24 hours. All right, so now I'm going to just turn to a few things related to food labels and menu labels, and a little bit about some of the recommendations that CDC has made regarding obesity prevention. This is the food label we have in the United States, Nutrition Facts. You know, food labels can help people understand the portion sizes are often larger than you think. And I think, certainly personally speaking, when I buy something and I consume the whole, let's say it's a mango drink that I like very much. And really, it's 2 portion sizes, and you know, really looking at this and seeing that, in fact, oh, this is 2 portion sizes. I have to double the calories that I'm actually getting in this drink. So right now, this is all there is in terms of food labels in the United States. But right now, there is an effort underway where the Food and Drug Administration, I took this right off of their website, soon will propose guidance for the industry regarding nutrition labeling on the front of food packages, and plans to work collaboratively with the food industry to design and implement innovative approaches to front of package labeling that can help consumers choose healthy diets. So there is an effort as well in the United States on food labels. I am not intimately involved in that. I've seen some talks, so if you really want to know more about that, I can connect you to people at the Food and Drug Administration who can probably help answer your questions. Menu labeling is another area that has been a priority. At CDC, there are what are defined as winnable battles. And these are public health priorities with large-scale impact on health and known effective strategies to address them. In the recent 2010 Act, which is basically our Healthcare Reform Act that was done, established national labeling requirements for specified classes of restaurants and vending machines. And so I think there was some discussion earlier about this, and there's some mention about some of the research about the results are inconclusive. I think that more work needs to be done. This is new, so to say what the effects of this are in terms of actual consumption is hard to know. And being an epidemiologist, I'd like to know exactly how people are actually obtaining the information that, you know, the data on consumption related to these labels. CDC also has a variety of obesity prevention recommendations. There are target behaviors for change. There are 6 of them: increasing physical activity, increasing consumption of fruits and vegetables, increasing breastfeeding, decreased consumption of sugar-sweetened beverages, which we are seeing now, this decrease in sugar-sweetened beverage consumption, a decreased consumption of high-energy dense, nutrient-poor foods, and decreased television viewing. And you can see that 3 of them relate to food, and the other 3 obviously relate to physical activity. Several years ago, CDC published the recommended community strategies and measurements to prevent obesity in the United States for communities. And in this guide, there are 24 recommendations for obesity related prevention and interventions. 10 of them relate to food, and the other, obviously, physical activity. So I'm just going to show you the 10 here. There are 6 strategies to promote the availability of affordable, healthy food and beverages. And I circled the public service venues in particular related to them because interestingly, at Health and Human Services, where CDC is part of another big agency, which is Health and Human Services, and there's a cafeteria in the main building, and that's been a kind of a test pilot where they have implemented a healthy eating cafeteria there. And so this is one of the areas that really people are working in is in these public venues, can we make healthy food more available and more affordable? And so this is one of the things that has been done recently. And the other strategies related to food are to support healthy food and beverage choices, restricting the availability of less healthy foods and beverages in public in public service venues again. So a lot of it has to do with the workplaces that are federal workplaces, in schools and healthcare settings, in daycare settings and places like that, to try to have healthier food. And I did, before I conclude, there was one thing I wanted to mention that I thought was really interesting when I was listening this morning when you were talking about, was it stealth health? I like that very much. And I was talking to Michael and saying how one of the things that I found very interesting, recently we published something that shows a decrease in adverse lipids in the US population. And that was true for children, and also for adults, and for adults not taking lipid-lowering medications. As you know, lipid-lowering medications have gone way up, and they do account for some of the decrease in, or the improvement in lipids, I should say. Actually, the medications really only affect your LDL. They're not going to affect your HDL. But in any event, we found this improvement in children as well. And so that's not from medication. So what's happening? And I think our theory is it's the removal of trans fats from the food supply. And that was invisible to the consumer. And we've seen this improvement in lipids, which is quite astonishing. And it was very exciting to see these data. So just to conclude, the obesity levels are very high in the United States. The increases were primarily in the 80s and 90s, and we have significant disparities in obesity prevalence. The dietary factors play a role. I didn't really talk to you about the research showing, sugar-sweetened beverages is related to obesity, but there's research showing you that. But I showed you kind of more of what's happening on the population level in terms of diet and some of the things that could be contributing to obesity. We've seen changes in calorie consumption, how Americans eat, snacking, eating out, portion sizes, and what Americans are eating in terms of added sugars and beverages in particular. I think that in terms of food and menu labels, understanding, particularly related to these things like portion sizes, eating out, and snacking, which are so relevant to what we've seen in the obesity epidemic. As we've seen that increase, we've seen these changes. So anything that can help inform those areas and help consumers in those areas, I think, would be beneficial. So thank you very much.
We have a few minutes for extra questions, and so we can grill Cynthia a little bit more before we let her get back to her dessert, which you'll notice was carefully chosen, and we gave you no choice. There was no other choice. So let's call for some questions from the floor. Somebody has a mic in hand already. Thank you.
Can you hear me? Thank you for a very interesting presentation. It's good to see a comparison with other nations to see where we are in the world. You talked a lot about sugar, but not about starch, and obviously they're a significant part of the other snack foods, and I'm just wondering what the trends are for starch in the United States over the timeframes that you showed this afternoon.
Yeah, I actually, after this morning, I thought, we need to be doing some analysis. I think I'm going to ask someone to do some more analysis and looking at starch. I think sometimes with the way the data sets that are set up, it's harder for us to look at we can look at carbohydrates as a whole and added sugars, but then other than that, it's hard to really disentangle the other starches in terms of complex carbohydrates. And I really would want to try to do that to be responsible in terms of doing analysis. So I'm not quite sure I can do, do as much analysis looking at simple carbs, which is, I assume, what you're getting at, is looking at, but it is something that I'd like to move forward and see what I can do with the data, because of course I'm constrained with what the data allow us to analyze.
Somebody's mentioned Mike, but maltodextrin use is increasing in Australia as well, based on evidence that I've seen. Of course, this company has reduced the sugar content, and they use blood nutrient sweeteners, they bulk it out with maltodextrin as well. I'm interested to see those data on that as well.
I think here in front.
You did very well to speak over all the knives and forks clattering. Thank you very much. While we've got you, I wonder if you could say anything about food wastage, which is becoming a bigger and bigger issue because the world population is going up and the production of food is not going to be able to match it unless we can reduce food wastage.
I think that's a really interesting question. I don't, with the data that we analyze, I can't really address it, but I do think that when you look at the data I showed on agricultural production in terms of calories, you saw this average, the average per capita increase was about 500 calories, whereas in consumption data it was about 200 calories. And so I think that a lot of that was wastage, although that does assume that the data we have on consumption was perfectly accurate, which of course dietary data isn't. But I do think that you see there a tremendous amount of wastage, maybe half the calories.
Yep, thanks.
Yeah, hi, thanks for the talk. I presume in America the farmers are struggling to survive as well as they are in Australia. You've shown that the portion sizes have increased over the years, and in terms of the percentage of disposable income, has the price of those portions increased or decreased?
Well, that's a great question too. I can't answer it directly, but I do know that I've seen some work some economists have done that show that food relative to income is cheaper than it's ever been, and so that could be contributing to the whole obesity epidemic. And I think that more work really on the economic side really does need to be done.
Yep.
There's some significant differences in the incidence of obesity between the different states. Do you have any sense of whether that reflects differences in diet habits, ethnic profile, or lifestyle?
Right, there are significant differences by state. I have to make a plug for this wonderful National Health and Nutrition Examination survey that actually is based on measured weights and heights, and the state level data that's based on reported weight and height. And so that I think that it's that they exist, but the state lines are somewhat imaginary. I mean, so that it's not as if one just goes into it. It bothers me slightly because of that. But I think that there are regional differences in diet, certainly. And I know that just as anecdotally, in defining sugar-sweetened beverages and talking with my colleagues in the South, they were adamant that we had to add sweetened tea. And because sweetened tea is so prevalent, people drink that all the time there, but I don't drink that. I don't, and I grew up in the North and we don't have that. So there are definitely differences in dietary intake and patterns throughout the country. And then the race ethnic makeup is different throughout the country. And so that when you have a higher prevalence in one race ethnic group that's more represented in a particular region, you may have higher prevalences as well. And one other thing, there's a great map. There are all kinds of data I could show you. There's a great map that shows obesity by the states, but you can put on it physical activity patterns too, and you can see they overlay each other so that physical activity is lower in the areas where obesity is higher.
Good map, fast food outlets too.
You could do it. Yeah.
Jenny Brand Miller. Thanks for a wonderful presentation. It's really nice to see the data for Australia and the US directly compared, because I think there's some really important similarities, such as overweight and obesity are very common and they've been going up at this in parallel. But there are some important differences that have been ignored, and our media doesn't know that something like trans fat and added sugars and soft drinks might not be as relevant in Australia as it is in the US. Mm-hmm. So, for example, our trans fats, they were reduced in foods to a very, very tiny level at least 25 years ago. So they make up a really small proportion. And yet we decide that it's important to have labelling on trans fats and other things that might not be so important in our context, because we don't look at those comparisons. Mm-hmm. And the second thing is sugars. Sugars have been going down in Australia, added sugars, refined sugars, and we've never had high fructose corn syrups in the amounts you do. But they've been going down consistently in terms of availability and in terms of food records for at least 30 years. Mm-hmm. And yet we make statements all the time about the importance of sugar-sweetened beverages to the obesity epidemic. So even at the end of your presentation, despite the fact that you showed that there was a reduction over the last 10 years in sugar-sweetened and added sugars, you still concluded that that was the only food in your final slide that you said was contributing to the obesity epidemic?
In my
Yep.
final slide, I didn't have any
Yeah.
foods.
Okay, it doesn't
No,
matter.
I mentioned, the CDC has recommendations relating to sugar-sweetened beverages, and I mentioned that there has been some research that shows a connection between sugar-sweetened beverages and obesity. There has been research that shows that, and I used it as an example, but not. It wasn't in my last slide. I didn't have any
Well,
food.
one of the things we do, which I find extremely frustrating, is, for example, our dietary guidelines start with the American technical statements and say, okay, this is law, this is proven, and therefore we'll take just the last 10 years of research and look at that with special reference to Australia. But they start with the Americans, and the Americans tend to be very parochial too in the research that they look at. So they tend to ignore all the research in Europe, which is really important from an Australian perspective as well. So I think I'll leave it at that point. There's lots of other things I could
That
say.
wasn't a question.
I don't hear a question, so.
Next up. Yep. We have a mic right here.
Thanks very much for your talk. One of your first slides showed that a plateau in the earlier phases of the obesity epidemic, that is, levels of overweight were quite high, say back in 1960. So two questions, and there was an inflection in the late 1970s.
About 1980, right?
Yeah. Did the levels just decrease linearly back to, say, 1900, in your view? And to what do you attribute the inflection in the 1980s or so?
Well, those are, I'm such a data person that I don't know what happened before 1960. But, I suspect there was some gradual increase. But we don't have measured data before 1960. And I think in terms of the inflection point, I think all these things that happened in terms of dietary patterns and the food supply, all were contributing factors. Of course, obesity is very complex, but all these things were happening in the background, that I mentioned about food portion sizes and eating out of the home. All these things were happening at that time. Unfortunately, we don't have data that is every year. So all I can say is that we had data from 1980, and then we had data again in the late 80s. So I can't tell you where the inflection point really was.
More questions. Tim.
Hi, thanks for that talk, Cynthia. I'm just getting back to that issue about the levelling off of obesity rates. You showed that overweight has remained fairly steady over the past few decades, 3 or 4 decades. And what's changed is the shift in terms of what might be considered normal weight and those categorised as overweight. And given the fact that the normal weight go through overweight before they become obese, could the levelling off not be a result of anything we're doing, but merely a statistical quirk, meaning that the people who are now normal weight are the ones that are somehow genetically or socially protected from moving into being overweight?
Yeah, I think it could be, but I think that this is one reason why I showed those, the whole distribution curves. And I wish I had shown one from earlier, because you can see, if I showed you a graph from the 1960s to today, that it's become way more skewed. And so that it's not just that there was a shift in the distribution to the right. It shifted to the right, that's true, but it became more skewed. And so I don't think it's just a statistical thing, but you're right that people are moving through. I mean, they do. If you're normal weight to become obese, somewhere along the line you were overweight.
Could I ask a follow-up question about that? I don't think you put up the trend data for the subgroups. So say, for example, low-income women, where there was I think it was 42% obese or overweight at the moment. That was the startling figure there. So have you done the trend charts for the subgroups that we could?
Right. We have done trend analyses for race ethnic groups and some age groups. It's a whole interesting. I've had a little bit of a debate with some of my colleagues about doing trends by income. We did do some by income and found actually some of the bigger increases were actually in the higher income group, the change. The prevalence in the higher income group was still less, but that the increase had been greater. And that's been shown in some other people's work as well. But there's some debate about what does it mean when you're looking at trends by socioeconomic group. Are those groups really comparable over time? And is it fair to do that? So.
We have one microphone in place here, so let's go over there and come back.
Hi. My question is around climate. I'm wondering if...
there you are.
Oh, hi, yes. I'm wondering if climate was one of the conditions or factors that's involved in any of the research you've seen, because I'm just thinking that on the side of weather changes, that would affect agricultural output and possibly what's supplied to the people, and on the other hand, the relationship of the human body to the climate as well, leading to maybe specific cravings for certain foods. Yeah, just wondering how that might contribute to your data.
Yeah, I don't have any information about that, but I think it might be an interesting area to explore.
Dan.
Yeah, hi. So I would like to find out what the trend line for the changes in physical activity or lifestyle looks like, and the proportion of the change in obesity levels, what fraction of that can be explained by people just like not exercising as much, or maybe like occupational shifts. You just move to a desk job instead of working on a farm, and you don't get enough physical activity.
Right. So that's the whole other part of obesity is the physical activity side, and obviously that's contributed. Our lifestyles have changed so much in terms of the type of employment, in terms of our leisure time activity. The measuring physical activity is tricky too. And this is why I love anthropometry, because you can ask people to get on the scale and you can measure them. But physical activity, that you can use accelerometers to do that, and that's a great thing. And one of the things that accelerometer data does show in the United States is that in terms of meeting recommendations, very few, a very low percentage of the population meets physical activity recommendations. In terms of looking at trends in physical activity, I don't really have access to good trend data on physical activity, partly because of the changing way that people are measuring it. Asking people how physically active you are that's a difficult thing. What people will do is often how much physically active leisure time activity do you do, or something like that, and you really don't see a lot in the data, and I think there are problems, kind of more data issues with that, and that's why the accelerometer data, I think, is really an interesting and area, and I hope that we can do more with that in the future. And we are actually doing accelerometer data down to age 3 in the survey that just completed in 2012.
Maybe we'll go to Becca first. Yeah.
Hi, I'm wondering about the very high incidence of sugar-sweetened beverage consumption and fast food consumption among young people that you mentioned. Mm-hmm. I'm wondering if that's an age effect or a cohort effect, in the sense that, is that behavior going to continue as those groups age, or is that like a quirk of being young, and being older or becoming older is associated with lower consumption of those things?
I don't know the answer to that. I bet you it's not all a cohort effect. That would be surprising to me. But I don't really have data on that. And I guess, we could go back and I could maybe look at data from, the 70s and look at sugar-sweetened beverages and see what the difference is. The thing is that I think we're doing a better job now collecting data on dietary intake than we were. In terms of methodology, has improved quite a bit. But that would be an interesting thing to look at. I don't think it's all a cohort effect, though.
We have time for one more question, and then we should let Cynthia have her fruit.
I see there's chocolate there. I'm looking forward to that.
I was at a conference recently where much was made of that small but significant decline in the percentage of calories from takeaway foods, I think it was, in the 40 to 49 year age group.
Right.
Do you have any indication whether they've received some message and they're acting on a message, or is it just statistically a blip?
Why? I don't know. Seeing even the recent potential leveling off of obesity, and in particular in girls and in women, People ask, well, why? And some people have theorized, which, I don't know, I'll throw it out to you, is that in female, and I get it relates to that particular age group too, but women tend to be the controllers of the diet, if you will, at home, kind of, and so they lead the way in terms of dietary change. And maybe that's true with that middle-aged group in terms of they're kind of running the household often in terms of what the overall dietary intake is and what people are eating. I don't know. A theory that I did hear somebody suggest.
Terrific. I think we should stop there and thank Cynthia for a wonderful